So hopefully my talk title will make sense. This is kind of a title of a paper we've written. Our group has kind of evolved since COVID and come up with some new ideas and ways of thinking. But a lot of it is, what we've been talking about for years, that healthy lifestyle is good for you. And how do we get more people to adopt that? So let's start with things that we already know, right? And that we don't talk about as much now because of COVID. But chronic disease, cardiovascular disease, diabetes, neurocognitive conditions, respiratory conditions, and certain forms of cancer were and still are and will continue to be significant health problems that we'll have to address. And then as we talk through this, there's indications that if we don't do radical things, may get much, much worse if the trends that we're seeing now continue. So we're going to kind of talk about those. But we know this, right? This is what we lived with before COVID, that cardiovascular disease around the world is the #1 killer. No reason to kind of go through this, but we really haven't been talking about it much, unless we've been kind of subtly talking about it in the context of COVID and outcomes. But it isn't at the forefront anymore. But it will be again, and there's indications it may be much worse. A little bit more about this, and then I'll move on. But 6 in 10 U.S. adults have a chronic disease. And that was before COVID. So we weren't really doing too well health-wise before COVID. And again, like how are we going to be when we come out of this? And so, it's good to revisit those dire statistics that we had, which is why we're all in the room, right? That chronic disease and chronic disease prevention and treatment are a big reason why we've chosen the professions that we have, is to make that better. And I still like to show this. This is an older infographic now, almost 10 years old, but I just like the way it's laid out, and it really hasn't changed that much. When you look at the chronic diseases for men and women, race and ethnicity, when you look at the factors attributed, a lot of it's healthy living, that it's physical inactivity, that it's smoking, poor nutrition, mental stressors now we're talking more and more about. So, we've kind of talked about chronic disease and lifestyle-related diseases kind of in the same vein, and it's true to a large degree that if we lived a healthier lifestyle, a lot of these chronic conditions would be much lower in incidence and prevalence, much more manageable. And so that's the shame of it all, right? That a lot of this is so preventable. Oh, that just went by itself. Now I kind of like to focus on physical activity because I'm a cardiorespiratory fitness person and a physical activity person, but you can make similar cases for poor nutrition and smoking and those types of things. But if you look at the statistics, and again, this is probably not something, we already know this, but it just stuns me, even me, every time I look at it, from the economic perspective and from the health outcome perspective. But if people were just more physically active, it would save billions and trillions of dollars in our healthcare expenditure, gross domestic product. It is a huge drain on the system, just being physically inactive. And it still stuns me that we talk a lot about physical inactivity. Why did you do this? Every time I shake the table, there we go. But is it still getting the credit it deserves? It's still not integrated into healthcare like it should be. And I'm on committees talking about getting a CPT code that we can bill for physical activity counseling, because it's not there yet. And when you look at this data and other data that's out there with respect to physical inactivity and health outcome, it's like, why hasn't it been there so long ago? And so, and then if you look at the effect of physical inactivity and how it contributes to chronic disease, we've known this, right, for for years. But again, I think it's important to revisit this because, and I guess one of the reasons why I talk about it so much is we all know this stuff, but still policymakers, it's somehow not resonating. So maybe that's why I keep putting it into my slides, because we need to keep talking about it, because we're still not there to people saying, yeah, of course, this is a no-brainer, but physical inactivity is a significant contributor to chronic disease. And if people were more physically active, the incidence and prevalence would go substantially down. Now, I'm going to kind of take a different approach throughout this talk in thinking about how we get the world to lead a more healthy lifestyle. And everyone's familiar, right, with the U.S. physical activity guidelines. And if I asked everyone, what is the desirable amount of physical activity that someone should do, moderate to vigorous physical activity per week? All right, on 3, let's all say the one number. 1, 2, 3, 150. Okay. But we're going to take a little bit of a different turn here and thinking in the message of something is better than nothing and more is better than that. And should we rethink that approach? And there's data to support that. So should we change our messaging paradigm and the way we counsel patients? And has that been one of the things that has been wrong with the way we approach things? It's this dichotomous all or none approach. And I'll make the case is it doesn't align with the literature as far as what's beneficial. And so we'll talk about that too. But along those lines, and this is, I think there's a lot, I'm Italian, so I think I'm, born to be pessimistic, right? But I really do like to think that I'm not a pessimistic person. So I see these indicators that we're moving in the right direction. And, Life Simple 7 is one of those things to me. It's not an ACSM movement, but American Heart Association, which is primarily physicians, and the fact that they came up with this is a sign of hope for the future, although it's been around for a while. And everyone's familiar with Life Simple 7, right? That it's common sense stuff. If you eat better, if you are more physically active, so on and so forth, you will live a healthier, a better lifestyle, or a better healthy life with lower risk of adverse events. But looking at the data, so if you start to look at Life Simple 7 data, and this kind of gets into that message of something is better than nothing. So if you take the ideal behaviors and characteristics, so there's lipids, blood pressure, blood glucose, but then there's smoking, body weight, physical activity, and nutrition, that if you go from, if you do everything right, so this is risk of adverse events, right? So certainly, if you emulate all of those, you're in great shape. Your risk is so low compared to, someone who is emulating none of those characteristics. But why don't we appreciate the fact that if you do some of these things and not get to ideal cardiovascular health, which is only about, if you look at the data, 3 to 5% of the population is ideal cardiovascular health. My gosh, isn't it, for the statistician people out there, we love stats and p-values. Going from here to here, you're not really living an ideal lifestyle. That's a big reduction in risk. And so Life Simple 7, and you look at the data out there, and a number of papers, not only on cardiovascular disease, but they looked at it in cancer risk. They looked at it with neurocognitive diseases, certain forms of cancer. Same type of finding, that if you go from, poor cardiovascular health, a poor metric, and then make some changes that aren't ideal, you have a significant reduction in risk from these chronic conditions. why aren't we having that bidirectional conversation with our patients? Why don't we sit down with our patients and instead of saying, here are the guidelines, all or none, what is it that your life looks like on a daily basis? What are you willing to do to make changes? You know, are you willing to eat a couple of servings of fruits and vegetables per week versus none? Are you willing to go for a walk a couple of times per week versus none? Why aren't we doing that? Because the data would indicate that's important. And maybe that's part of the problem why we're not moving the needle, is because imagine if you have somebody who is living in, you know, a very unhealthy lifestyle, and they're talking to their healthcare provider in a very short setting, and they say, well, are you physically active? No. I don't want to hear about any of that. And then say, well, here's the guidelines. Let's say it again. What's the number? 150 minutes. How likely is someone going to say, well, okay, I'll go from 0 to 150. That makes sense to me. Versus, how about going for a walk a couple times a week? Can you do that? Oh, and is that healthy for me? So why aren't we doing that? Why aren't we aligning our practice with the evidence that's out there? We were talking about it at dinner, implementation science, and that's true implementation, right? And certainly we want to not undersell what it is that's valuable, but maybe that's part of the problem. I felt that way for a while, is we're not being reasonable in where people are starting and where they need to go. So, and again, we'll talk about that throughout the lecture as well. I still love this study as well for the 2 slides that I'll show, but this was large cohort study. I love big studies because, you know, you can't really argue with the data when you're talking about tens of thousands of individuals. So this started in Swedish men looking at cardiovascular disease, and then looked at women, several thousand women. Same kind of thing, that in cardiovascular disease, if you lived a healthy lifestyle, you could pretty much prevent premature cardiovascular disease. And again, this is no surprise. So why don't we have a billing code? Why aren't exercise physiologists licensed healthcare providers? Why are we still talking about, why is this slide set still moving every time? Okay, so, but why? You know, and so maybe this is part of the why. When you look at, you know, this was an editorial, and I liked the bottom part. Great majority of cardiovascular events are preventable. Yeah, by healthier lifestyle. Yeah, that's true. But then look at complementary. Really? And when I read that, it's like, so you have this data that say, if you lived a healthy lifestyle, you can prevent most of these, you know, premature conditions. Isn't that mainstream? And then to call it complementary, so something's still missing there. So I think, and maybe that's the part we've kind of fallen asleep. It's like, well, everyone knows this. Everyone realizes this is the truth, and we've stopped talking about it. Maybe we need to not stop talking about it, as boring as it is maybe to us, because we already know, but clearly that's not, you know, happening everywhere. And then, you know, so shifting on, and my career started I ran an exercise testing lab, a CPET testing lab, mostly working in heart failure and cardiac rehab. But over time, you know, I started to evolve into this, how do we move towards a preventative model where before people, you know, have something bad happen to them, how do we keep them healthy where they live, work, and go to school? So my group and I, we've written a lot about this, and now we're starting to write a lot more about this during COVID, and we'll kind of, you know, talk about those things. But, you know, so these are some of our initial papers, and we've been writing about it again for a while, that what we do in cardiac rehab, we've been doing it for a long time. We don't get most of the patients who are eligible for cardiac rehab to come, but it's healthy living medicine. We've kind of talked about it in that way, that healthy living is medicine. It's a poly pill that comes in different forms and shapes and sizes that everyone should take. So why aren't we doing that? And we should think about these healthy living medicine initiatives or interventions more broadly and have a system that pays for it. So diabetes prevention programs kind of, you're start to see some signs of community-based interventions that are emulating that. But we've been writing about it for a while, this preventative healthcare model. And that really is the future, right? Especially now as we start to talk about the COVID data that's coming out and some of the things we've been writing about and seeing. Who we are as exercise professionals, again, it should just be, there should be a much more readily available access to our knowledge base and the interventions in the healthcare that we can provide. So how do we get there? And I'm worried, I am skeptical as I'm part of these groups that have these conversations that I don't really see a clear path forward to that. And we're not going to talk a lot about Australia, but Australia is the only country that I'm aware of that has some rigid, or not rigid, that's not the right word, but a formalized structure for licensing or accrediting exercise physiologists. There's a billing code, and their services are readily available. And these conversations I have and these groups that I'm on in the U.S., I don't know how we get there, and that bothers me to a degree. But then also thinking about healthy lifestyle interventions, and we think about who the stakeholders are, and we think about healthcare, and we're all healthcare providers. But I think we need to think a little bit more broadly than that, and we've written about that as well. And thinking about like all of the different stakeholders with respect to healthy living medicine. And we wrote this European U.S. position paper a few years ago now, but this is everyone's problem, right? The public health, school systems. We talk a lot about employee health and wellness and the opportunities there. The healthcare system is just one piece, but if we're really going to make a change, a dramatic change, we need to start emulating something like this, where the healthcare system gets rethought into a primary prevention model, where we have many stakeholders we don't usually envision as being part of healthcare, but my gosh, they are, and we really need to think this way. And with healthy living medicine, there's not a better opportunity out there. It's not like surgery, where you can't do a model like this, or pharmacy for a large part, but with counseling and promoting physical activity, healthy body weight, not smoking, and good nutrition, it works. It works for this. And I talk about this too, like wearing, I have a PT degree, I have an exercise science degree, I run community programs in my department, I have a faculty practice, we have educational programs. No one discipline should own healthy living medicine. It should be all hands on deck, and we should all talk about it. Some of us, should talk about it more than others, so we have more time to talk about, the nitty-gritty of the counseling. But pharmacists, dentists, physicians, people in grocery stores, like as far as messaging, we all need to kind of create a culture where people are immersed in healthy living messaging, and that's where I'd like to see it go. So that was all pre-COVID. I still think a lot about this, but and then I stayed home for a long time and still ran a department and thought about my science and started to think about what the world was like now, and started to get worried more, and we started to think a little bit differently about things. So let's jump into the COVID pandemic era and what it means for us. And we're kind of talking about it, about how healthy lifestyles and healthy living play into this, but I don't think we're talking about it as much. So this was, as I got this slide set ready, I pulled a snapshot from the World Health Organization website, and it's way higher than this now as far as the numbers of COVID cases and deaths and so on. So, buckle up. We're we're going to deal with this for a good while longer. And then we're going to emerge from the pandemic, but the ramifications of the pandemic are, how long is that going to go on? So one of the first papers we wrote before we started HL Pivot, as I get older, it's kind of weird, right? Like I feel I'm really proud of like some of the papers I've written, and they have really boring titles. Maybe, for you emerging PhDs out there, and it gets cited like, 15 times and all of this stuff. And it's like, my God, that's a good paper. And then, again, COVID, I'm sitting around the house, I'm thinking more. And I say, whoa, okay, Tale of Two Cities. My gosh, that first paper up there got cited so much. And it's like, really? Just because of the cool title? And it's like, oh, okay, so PhDs out there, writers that are out there, if you're creative and can think of some cool titles, it kind of works a little bit. But that first paper, we wrote this early on, thinking about, okay, so the world's locked down. We have social distancing. Schools are closed. Businesses are closed. Gyms are closed. People are staying away from each other. What is that doing? We're already in a physical inactivity pandemic, right? The Lancet series in 2012 already labeled physical inactivity as a pandemic in and of itself. And then you stack this on top, and so who's read Tale of Two Cities? A couple people. So you have London, which is supposed to be safe and stable, but has a lot of inequity, and then Paris, which is in the strife of civil war and so on. So, and London, that's supposed to be safe, has this warning sign. So now we've got a tale of two pandemics, right? And how will they impact each other? And we didn't really have data at that time. We were just worried to say, this could be really bad. It could get worse for the physical inactivity pandemic, and then the lasting effects of that. So that was our first paper. And now, the second paper, which just got accepted, which also better get cited a lot, because again, I came up with a cool title. That's all I do now. My papers really are useless now. It's just the cool titles, and they get cited a lot. But now we have data, and the second paper, which will be out soon, again, just got accepted, kind of talks about like our concerns will people become less active, and you could make a good case that if you aren't active and healthy and you get a viral infection, there's not a lot of data out there before COVID, you're in big trouble. So this is bad. That was the first paper. I hope it doesn't turn out that way. And then the second paper was, yeah, it is bad, and it did turn out that way. And so then it's, at the end of this talk, we get to the point, it's like, well, what are we going to do about this? How are we going to get out of this? So initially, let's start to talk about some of the data now. Initially, there was like this little glimmer of hope during the lockdown, right? And through internet searches, that the number of people who started searching exercise or, walking or whatever went through the roof. So there was an indication like, okay, well, I'm locked down. Maybe it's time to reflect and change my life to a degree, and maybe I'm going to exercise more. So it's like, oh, maybe there's a silver lining here. And then, there we go. No, is this the one? No, yeah, and then the data started to come out as far as what actually happened. And this is just a snapshot. There are many more papers around the world that are looking at physical activity patterns from kids to older adults. Some of it used the Argus app, so using mobile apps. Others used surveys of their the parents of children. Others used surveys of adults, and are you more or less physically active? And the world is moving even less. I don't think we can argue with that impact of COVID now. that the world is moving even less. Think about that. I think we lose sight of how bad it was before COVID, and that we were trying and putting out position papers, and the U.S. Physical Activity Guidelines came out in 2018, painting a pretty dismal picture about physical inactivity. We've written a lot about it, and now we're moving even less. That is really bad news in and of itself. What the heck are we going to do about that? And then if you think about how hard it is to make behavior change, right? So we were here, now we're here. So what are we going to declare victory if we get back to where we were with respect to physical activity, which was already abysmal? I'm worried. I'm worried with this data. And so again, it's time for pretty drastic change with respect to what it is we do, with respect to the way we approach healthcare. And I don't know how we wake people up yet. I don't think that's been really showcased, although the data is out there. And again, I'm not going to talk as much about unhealthy food consumption, but it's the same. It's the same poor picture that people are moving less, and you think about, especially the Western diet, it's even worse, a lot worse. And so people get used to that, and is that the new norm? And are we going to celebrate getting, if we can even get back to where we were pre-COVID? It's not good. It's really, really not good. And again, these are just other snapshots of, how many people are reporting moving less to a degree, moving a lot less. Very few people have been reporting in these studies moving more, doing more physical activity. Very few. Most people say they're doing even less. And then if you break it down because we already had this inequity gap, with underserved populations and minority groups, and that gap is even widening more. And so there's problems within problems if we really start to dig into that data. So that was the first wave, right? That, okay, we're eating worse, we're moving less. Even now, usually we wait decades, right, or years to say, yep, this is what's happening. I don't think it's too early to start sounding the alarm. I mean, looking at not one paper saying, oh, nope, it's going the other way. It's all going pretty consistently in large cohorts around the world. And then here comes the second wave. What comes when you move less and you eat more calories and a less nutritious diet? What happens then? You gain weight, right? That unhealthy lifestyle, weight gain, chronic disease sequence. So we got the first, and now we're starting to see the data. And again, these aren't small studies, and it's in our kids, but this is, survey data from the United States, 2 to 19-year-olds, significant upticks in weight gain, things we've never seen before. And are we surprised? I don't think any of us are surprised that this is the case, right? That this makes sense. Eat more, move less nutritious diet, you're going to gain weight. And so now we're already seeing that. And this is not the only study out there that's showing that. So there's other studies showing that as well, that this is in fact the case, that there is significant weight gain on a population level. So what's going to happen 5, 10, 15, 20 years from now? And we were already in a chronic disease pandemic. That was already characterized as a pandemic as well. What's going to happen if we don't make drastic change about that? So, okay, let's shift gears, right? So the other part of the papers that we wrote were expressing concern about what's going to happen with healthy lifestyle behaviors on a population level. But then, when there was a few papers on influenza and who gets hospitalized and who has resiliency to fight off a viral infection. And we look at the athletic literature, and if you're an extreme athlete, you have a higher risk of an infection because your immune system gets knocked back. But people who exercise, moderate intensity, eat a good diet, like they have immune resiliency. So it would make sense to say that, or it would make sense to express concern that with the COVID pandemic coming, and we have a high prevalence of overweight, obesity, high prevalence of physical inactivity, high prevalence of poor diet, we're in big trouble because we're not ready for a viral pandemic. And what did we start to see? The initial papers, if you took it to the end conclusion of, chronic disease is a lifestyle-related disease, and if you have obesity and these other things and cardiovascular disease and comorbidities, you're in big trouble. And lo and behold, you start to look at these papers, the initial papers that came out with respect to who was at risk for hospitalization, ICU, and admission and intubation and death. It's those people who were obese and had chronic diseases coming in the door. And how did they get there? Right? We already know how they got there. A lot of patients got there. So we weren't ready for this. So that was starting to come true. And then we started to see papers about, theoretical papers about low cardiorespiratory fitness and mitochondrial function and immune function in the ability for COVID immunity. So making these good theoretic rationales like, hey, it's not only that this leads to chronic disease, but even if you don't have chronic disease and you're not active and eating well, you could be in big trouble too. And then what started to come out? The papers on looking at physical inactivity, and these are big studies again, UK Biobank, Kaiser Permanente data that, they have done the physical activity, the wonderful work in the physical activity vital signs. So they have large health system related data that ask the question, how physically active are you? And they have a lot of COVID infections, a lot of hospitalizations, so very powerful data sets to look at. And what happens, right? And are we surprised at this? That people who reported being physically inactive were at significantly higher risk. It's an independent contributor to hospitalization, ICU admission and ventilation, and death. And it's right there, right? And then other studies started to come out showing the same thing. If a patient reports being physically inactive, leading a sedentary lifestyle, it's an independent predictor. And then here comes the Biobank study, or the Kaiser study. Again, almost 50,000 people, same thing, independent predictor. Now, thinking about this, something is better than nothing, and it's interesting, it gets buried in the messaging, because I'm past the point of thinking we are going to move the population from sedentary to ideal. Who believes that's true? Like, that's a realistic goal. It's not. Right? Even the U.S. Physical Activity Guidelines acknowledge that something is better than nothing. Why do they do that? Because that's more realistic. And what's buried in these studies is they compare no activity, a sedentary lifestyle, to some activity, but not meeting the U.S. Physical Activity Guidelines, to meeting them. And then what gets promoted mostly in this study is that if you compare the sedentary group to the ideal group, it's a significant difference in hospitalization and COVID severity. But same thing if you compare the sedentary group to the intermediate group. Something is better than nothing, and we need to start to get on that train and promoting that to move the needle, I think, my opinion. And again, more papers are starting to, like every paper that's looking at this, that's actually collecting physical activity data is showing the same thing, that the people that are hospitalized, are those more likely to be physically inactive. And then, you think about physical activity and cardiorespiratory fitness, and cardiorespiratory fitness is a vital sign, and physical activity doesn't explain all the variance in cardiorespiratory fitness, but a big part. And so studies out there that have looked at, had data on exercise capacity, have shown if you have a higher exercise capacity, a much lower risk of hospitalization with COVID. So being physically active, having a higher cardiorespiratory fitness affords you resiliency to a viral pandemic. That's not shocking, right? And the data's there. So how do we start to package that? And then, when you think about mental health too, and this is, I think this kind of falls into healthy living medicine in a number of ways. The impact that being physically active, living a healthy lifestyle has on mental health, but also just being able to address mental health, I think falls within our scope. We're not experts, let's say, per se, but we know how to refer and to address or recognize when someone may be suffering from depression and anxiety and so on. But the world is more depressed, more anxious. It's mental health is not in a good state. And then you think about, okay, people are less physically active, eating more unhealthy diets, and their mental health is not in a good place. And then you think about the behavioral aspect of it, and it's like, well, how's this all going to work? How are we going to get people to be, more active? But there's a lot of studies now that are addressing this mental health piece. And even if we said mental health is not within our purview, which I think it is, you look at this data and you think, wow, that makes our job all the harder to make lifestyle changes if this is the way it looks. And again, this is just another slide as well on mental health, but it's a big problem, and we need to be aggressive about that as well. So kind of the third part of my talk is, and I've kind of been talking about this, it's a time for a change. And again, I don't know how we get there. I never really used to say that in my talks. I kind of more talked like, well, this is the data and this is what we need to do, and I don't know how we get there. And I think it's going to take more than just us in this room or we all need to be inspired to be thinking about it differently and be promoters of this message. And it's going to take a lot of people, I think, to do it with a singular voice. And I didn't bring this up before, but this is one of the mindsets we're fighting right at. And I should have talked about this more with the physical activity piece. I'll just say it here and I'll revisit it. There was this is pre-COVID. It was a qualitative study, and they interviewed women of varying levels of physical activity, and they wanted to identify barriers to being physically active or why some people were physically active. And so one woman said, and I quote from the paper, I took the slide out, to kind of consolidate things. Walking my dog is a barrier to me being more physically active. That was what we're up against before COVID, because the message is, if I'm not doing 150 minutes or more a week, what's the point? So walking my dog is a barrier to be. Something needs to be done about it. And now we're in COVID and people have the mindset that they do. We need to drastically change the way we talk to people, the way we listen, the way we message, the way we try to change the healthcare system. So this was, again, who knows where this is going to go. One of my, again, sitting at home in my Angry Bird pajamas, a nice dress shirt, and then Zoom Angry Bird pajamas on the bottom, because that's what we all do, right? That we get on Zoom, we have pajamas on. Is it just me? Really? That's not true. And then you're panicking, like, don't stand up, please don't stand up, don't really stand up. So, Angry Bird pajama moment, I'm not ashamed. If you want to be ashamed, that's fine, but I'm not ashamed. But, thinking about, well, how do we change the mindset? So, we came up with this acronym, Healthy Living for Pandemic Event Protection. Given, we have viral pandemics, but we have chronic disease pandemics. And how are we going to do this? And then I started emailing people from around the world that I knew, and then their colleagues. And let's start a network, and let's start talking and thinking about things and writing, sharing ideas and grants. And it's been, I think, kind of successful to this point. It's been a year and a half, and I think using the HL Pivot, we have a couple consensus statements out, over 50 papers on PubMed where people have used the HL Pivot affiliation. So I'm encouraged. We have a social media platform, but I think the intent was just it's just one way to try to change the message and the dialogue. And it's not, I'm not presumptuous in any way or thinking, oh my God, this is going to change the world. But we all need to start having different and good ideas to start changing things. So this was my idea, right? And this is an example of one of our papers. What we're facing now, so everyone knows what a syndemic is, right? Two or more health conditions that negatively impact one another. Chronic disease, unhealthy lifestyle, and now the COVID pandemic is a syndemic. It's the definition of it. And how do we get out of it is by leading a more healthy lifestyle. So what we've characterized, I think maybe, I don't see many people talking about it, but syndemic uncoupling. And the way to uncouple it in a big way is through leading a more healthy lifestyle. We've also been talking a lot about social justice and having a social justice arm to this, because if you look at the inequities with COVID, and then you look at the inequities with chronic disease and those underserved neighborhoods, it's even more dire. It's really terrible. And so how do we address that? And I think that's part of our responsibility as well as health professions, is to deliver healthy living medicine to everyone, but think really hard and aggressively about how we help these neighborhoods and these communities out in different and creative ways. We're writing papers about exercise science and the importance of exercise physiologists being in the healthcare system to address this pandemic, and to people with long COVID syndrome. We've written some about that. So shameless plug, I guess. I encourage you to kind of look at some of the HL Pivot stuff if it interests you, and see if it inspires you to think a little bit different and come up with a better idea, right? Like, that's my whole point of a scientist, is hopefully, none of my stuff gets talked about in a while because other people have had better ideas or disproved some of the stuff that I did and inspired them to think that way. So I really hope no one talks about me or the work I've done in a while, and I become invisible. And if I can look and say, things are progressing, but they're talking about other people, I'll feel really good about that. I think that's my job as a scientist, is not to promote myself, but to just inspire other people to say, that guy's crazy. I know better than him, and I'm going to show him. Go, please do it. I want you to do it. And then thinking about some of the things, and maybe this will inspire some people, right? Like, I'm a department head. I have a little bit of flexibility in things I can create in the clinic. And UIC really is a crazy place, but a wonderful place. I've never been in a place where, academia is usually very linear. And they say, I want to do this. Well, that's not the way we do it. And the day I got to UIC with my dean, and it's like, I want to do this. Oh, okay. Maybe, and I think from that we've really done some inspirational things, and so here's a snapshot of some of those. So we actually started. So we have a faculty practice with PT. We generate revenue. We have research in there and educational experience, enhancing the educational mission. But with the revenue and building the sustainability around that, we started a physical activity clinic. We can't bill for it, but it's the right thing to do. So we hired a faculty member who, has a behavioral counseling approach and a kinesiology approach and expertise, and she's taking referrals from general practitioners and others and counseling people, mostly from underserved, underprivileged neighborhoods, on how to be more physically active and having that bidirectional conversation in our clinic. I think there's a great opportunity for kinesiology and exercise science departments to approach a hospital system or a clinic and say, look, just give us access, right? And we'll hire a faculty member, maybe do some research and oversee a physical activity clinic, and we'll man it with students and start a physical activity clinic and would not charge for it. So the academic center wins because you enhance the educational and research missions of the students and the faculty. And you have a tremendous impact on the community. The healthcare system or the clinic provides enhanced care that benefits the patients they see, and everybody wins. So I think that's a tremendous opportunity to think about having those discussions and those partnerships. Another thing we did, so we partnered with a school, a private, not-for-profit, faith-based school that could move quicker than CPS, that is 100% Black and Hispanic students from really neighborhoods where students struggle traditionally. And I hired a faculty member who's I'm in a PT department, hired a faculty member as a master's in education leadership and was a CPS second grade teacher. She's a faculty member. She runs the Health and Wellness Academy, basically a health and wellness curriculum for that school, and takes students over to teach them how to run a health and wellness curriculum in a school. We don't charge the school. It enhances the educational mission. They want us to do research there. So thinking creatively out of the box. I think there's a lot of opportunities in educational systems to think creatively about their academic programs, their community engagement, and how they do these things. We also started a nurse-run clinic in Altus Academy, so now the families get health care. Think about families, usually if they access health care, so they go into the ER. Now they walk into their school, they drop their kid off, they go to the basement, they go and get their health care through a nurse-run clinic, and then if they have other issues, they get a referral into the UI health system. So I guess what I'm saying is I'm not bragging. I'm saying think create, like what is it that you can do that maybe doesn't make you money, but it's mutually beneficial with a partner and you can absorb it in your bigger enterprise because it's just the right thing to do. And there's no one right model to healthy living. Like we need to think creatively about this. And then, this was an interesting thing. And then I kind of revisit this, how much physical activity in the next section. So there's starting to be papers about this. They said diet-related diseases pose a major risk for COVID-19, but it's overlooked. Duh, it's overlooked, right? But you could say the same thing about physical inactivity, and they kind of talk about it in this paper. But Boris Johnson, Prime Minister, right? Prime Minister of the UK, he got COVID. He got really, really sick, and then woke up and said, man, I got really sick because I wasn't resilient. Started jogging, making some lifestyle changes. So, okay, we're writing about this, but isn't it time? Isn't it time to really start to make a change? Because if it's not now, if we don't make a change now drastically and learn and emerge from this and look at the data that's out there, it's not speculative. Are we ever? If we don't do it now? I don't know. And then thinking about how much physical activity you need. I already talked about this, but just to revisit it with a couple slides as I wrap up. And this isn't, things we talk about as much. But Chip Levy is I love this study from Chip. So if he just looking at a running study and looking at people, and this is mortality and cardiovascular events, taking people who are not, probably blinded a couple of people, I didn't shut the laser pointer off, looking at people who, don't do anything, and then go just to the next category, which is running 1 to 2 times per week, less than an hour per week. That's the biggest bang for your buck. And then it kind of levels out. So why are we telling everybody that they have to do what? 150, why? And we can continue to strive for that, but I just don't think it's realistic to tell somebody who does 0 to say, here it is. And I don't think maybe we intentionally do it, but I think that's the message that the public is hearing. And then it's like, well, it's not 150, then what's the point? It doesn't matter. And then, cardiorespiratory fitness is a vital sign, right? But you don't have to be, high VO2 max. Studies have shown every 1 MET change in fitness equates to somewhere around a 13% reduction in cardiovascular event and mortality risk. 1 MET, 5 METs to 6 METs, 6 to 7. So you don't need to be, and that's, I think, another misperception. You think about society and commercials and those things like, well, if I'm not this, then what's the point? And how do we change that messaging? Same thing with quality of life, right? Like a little is better than none. You know, that it doesn't take a lot to change people's mental status and those types of things. So we've been talking more about this let's talk about moving piece. You know, it's not only when you talk about moving, it's your exercise program, because studies have shown as well, it's not just your physical exercise program, but how often, like how much do you sit in a day, and how many steps you take in a day. So if you got someone to take more steps or sit less, but maybe they're not exercising, what? You're not going to praise them for that? And why not? Because the data says that those are beneficial as well. So when are we going to start to talk about this a little bit differently? Same thing with nutrition. If there's a dietitian in the room, they're going to kill me. But you know, if you look at the PURE study, which is an international study, I think over 300 countries. Okay, next quiz. How many fruits and vegetables do you need to have a day to be healthy and reduce your risk? How many? 6. You're overachieving. 5, right? That's what we've always heard. 5. But the PURE study showed 2. What? You're going to argue with me now? But the PURE study showed it plateaus at 2 to 3. So again, if you get somebody that's not eating any fruits and vegetables, and then it's like they know, well, it's 5 because that's what everyone tells me. So I guess a couple vegetables a day, a couple pieces of fruit, that doesn't matter. So whatever. Something is better than nothing. And even the ACSM says that with their, you know, staying fit during COVID. They talk about physical activity and exercise, and as they should, because we should all continue to strive. But move more, sit less. Move more, sit less. And we need to talk about this a lot. And then celebrate, and then know, here comes the art of clinical practice, right? Know when someone's hit their limit and they're just not going to do anymore and back off. You know, hey, so you're willing to take a walk? Yep. Okay, how's that going? Great. You want to do a little bit more? Nope. Why are you going to push? Because what are they going to do when you push? Back to nothing. So it's that art of practice. I think we need to rethink all of this stuff. All right, I'm done. Thank you for listening.